and overseen by Ashley. I think at the moment we have 25 FTEs, is that right? So we have 25 full-time people devoted just to the clinical research footprint, all overseen by these two outstanding leaders here. Wade Sachdev was a neurosurgeon in this department. He was an old school neurosurgeon, having done full residencies in head and neck surgery. He came to the United States and became Leonard Mallis's first partner. I'm the only neurosurgeon that Dr. Mallis actually trusted to do his cases and cases with him. He was a gifted teacher and a very, very versatile surgeon. Some of you who are in the room had the pleasure of working under him and with him. His wife, Ronit, was a neuropathologist, and together they eventually funded this with his family and his daughters, both of whom are physicians. So we remain grateful to the Sachdev family. I don't know if any of the daughters are listening today, but we certainly remain very grateful to the gift that you made, for the gift you made that supports them. Here you see the previous, a very illustrious group that you are joining today, some of whom are international figures and many of whom have contributed massively to neurosurgery research. Oh, and here we go with the, I'm sorry, I didn't know this slide was coming up, but here are the two accomplished daughters of the Sachdev family, one in neurology and one in vascular surgery. So with that, I will turn it over to Dr. Isabel Germano to introduce this year's invited guest.
Thank you. Good morning, everyone. It's really nice to have this opportunity to be in person and on Zoom. It is really fantastic to see how Research Day has progressed over the years. And my gratitude goes to Dr. Sachdev, with whom I worked and was also my patient, and from whom I've learned a lot. And really thank you to Olka and Rivka for your friendship and for being role models, each of you. Today is a great day, and I would like to thank Peter Morgenstern for being the backbone of all the organization. Your patience, your dedication, Peter, is second to none. So thank you. And here we go to be able to introduce our guest of honor, Gelare Zadeh. I've known Gelare for a very long time. As you know, the field of neuro-oncology is relatively small. And when I was elected president of the section on tumor, there was no question in my mind that Gelare and I would work even closer. And so I chose her as my scientific chair for our scientific meeting that will occur in Washington this year. Could I have the next slide, please? So just by the way of introduction, Gelare is Canadian, although she, her ethnicity is Farsi, but she was educated in Canada, as you can see on the slide. She did her MD at University of Manitoba and then continued on with the neurosurgery fellowship, the PhD, and her fellowship, neurosurgery residency, PhD and fellow at the University of Toronto. She is also a fellow of the Canadian Institute of Health Research. Next slide. And Gelare has been focusing her career on both the clinical and science aspects of neurosurgery oncology, in particular skull base. She has a very active research laboratory focusing on integrated multi-platform molecular analysis of brain tumors. She has been a leader and a pioneer on this. And she has been publishing on many very important topics, such as angiogenesis and metabolic inhibitors. The list of awards is second to none. as the chair of the section, it is my privilege to choose each AANS the recipient of the Bittner Award and lecture. And there was no question in my mind that for this first year, 2023, Gelere was going to be that person. And so she was awarded the Bittner Award at the AANS 2023. She has also been involved in a number of national and international organizations. She's the past president of SNO. She's currently working with the World Federation of Neurological Surgeons in the chair in the Women in Neurosurgery Committee. And she's co-chair and founder of the International Consortium on Meningioma. And she's the editor-in-chief of Neuro-Oncology Advances. So Gelere, thank you so much for joining us. Thank you for taking the time. I do understand that you had a good beginning of your journey last night, being able to talk with some of our residents, and I hope that today your journey continues to be a successful one. Thank you.
Where are the slides? Oh, here.
Perfect. Thank you very much. It's nice to see you, Isabel, on Zoom. Thank you again for inviting me. It's really an honor, and as you mentioned, to be joining the long list of very recognized neurosurgeons who you've invited for this lectureship. And it's an amazing opportunity to be here and to get to know your department. And last night, as Isabel mentioned, it was a really wonderful dinner, and especially just meeting the residents was really nice to talk with them. I did want to take a moment to mention Isabel, who, as you know, is the chair of our tumor section. And usually people at home don't know when somebody's doing all the work internationally. She spends innumerable hours on making sure the tumor section works well. And I have to say, of all the chairs that I've experienced at tumor section, she's the most involved, engaged, and she's really changed the culture of the tumor section. So congratulations, Isabel. And thank you for your nice comments about me. So I don't think I need to tell you the main type of brain tumors that we deal with, pituitary macroadenomas that we resect endoscopically, and we're able to actually restore visual function, and thereafter very little needs to be done after surgery. The next type of tumor, I think that we've evolved significantly, and this is always really now done endoscopically. Of course, it's dependent on surgeon preference, but I think this generation and beyond will likely continue to do these endoscopically. The next tumor that we see a significant evolution, and at our place, 80% of acoustic schwannomas are treated by gamma knife, is the acoustic schwannomas, where you could see here the gamma knife image that the treatment plan is based out of. And we really only operate on tumors that are greater than 3.5, and we go with a volumetric cutoff for ourselves. Meningiomas is what I wanted to talk to you about today. I think it's a tumor that's really not been studied to much extent. That's always been considered surgical and benign. And so for the subtypes that are very aggressive, we really don't understand the biology very well. And then the next one, I wanted to show you some results that we've had are the typical tumors that majority of the field actually spends a lot of time, energy, and funding to understand better so that we can improve outcomes. And unfortunately, the outcomes remain similar for the last 2 decades, which is glioblastoma, which despite adjuncts that we introduce remain the same. I think if you think about the treatment paradigms for brain tumors, you would argue that it's relatively linear. A patient presents with a symptom, they have an MR diagnosis, the tumor is such that it requires surgery, they go on to surgery. On occasion, they go to surveillance imaging and only intervene when the tumor characteristic changes. At the time of surgical resection, we then typically currently wait for about a week to 10 days to get pathology back. And then we have some molecular features that we've layered, which I'll show you addition of the WHO 2021, but really it's dependent on IDH, 1P19Q, MGMT, and the new WHO classification layers a few more molecular features. But then after that, we go on to a fairly standard treatment, which we all refer to as the Stupp protocol with chemoradiation. And then when that fails, we go on to clinical trials, which unfortunately are not very successful. So can we change, based on molecular information that we have, some of that linear treatment paradigm? In 2018, there was a seminal paper published in Nature by the DKFZ group in Heidelberg, Germany. They took approximately 3,000 samples, and it was based on approximately 80 different brain tumor types. They analyzed the tumor by methylation, and you could see that on this t-SNE plot, and I don't think you could see it projected well, but this demonstrates that each tumor really has a very distinct methylation signature, similar to a fingerprint. So the IDH wild type tumors are here and the IDH mutant tumors are here, compared to, for example, the ATRT mutated medulloblastomas. So the methylation signature is very distinct. And in this study of all comers, they showed that there's approximately 15% improvement in accuracy of diagnosis. So that's a significant clinical amount. We then integrated methylation at our place, and I have to credit the neuropathologist at the time who was at Toronto, Ken Aldape, who introduced methylation. And we then did a study on the impact of this to our clinical practice. We integrate histology with methylation. On occasion, you have to look at copy number variation because that t-SNE plot I showed you may not be precisely informative. And then we come up with an integrated diagnosis. So this is the column that shows you the diagnosis based on histology, and you can see the degree of crossover when we integrate it with methylation, which is significant. There's a considerable crossover. Now, for example, a regular glioblastoma that has no concerning features or questionable features, we don't do methylation on those. We rely on histopathology and molecular features. But we do look at the diagnostically challenging cases that we manage in UHN at University of Toronto. And you could see that of the diagnostic challenging cases, so where one or two pathologists can't reach consensus, they can't really come up with a final diagnosis, where the surgeon and the pathologist have perhaps a disagreement on the grade or the diagnostic entity, and whether or not we were able to get molecular features, those are characterized as diagnostically challenging. 84% have had a change in diagnosis based on methylation. So of that, it's 24% had a change in their diagnostic entity. So the pathologist said it was a GBM with methylation, it was a brain met. There was a 31% resolved differential diagnosis where the consensus was not reached between the pathologists, and 27% had a change in tumor grade. So again, significant. The next question then is, well, this is good, but what do we do for patients clinically? So we looked at the change in decision clinically for the patients that we reviewed, and there was a 15% change in clinical decision-making. So again, a very significant clinical number. And I would highlight one particular case, which is a young lady who had just finished undergrad, had a frontal tumor resected at an outside hospital. 3 pathologists, internal and 1 external, could not actually reach consensus on what the diagnosis would be. They called it high grade, not otherwise specified, and the tumor board recommended chemoradiation. At a time when this was going on, the father heard me present somewhere, he's in the medical field, and asked whether we would do methylation on the daughter's tumor, which we did, and the diagnosis is a DNET, and so she didn't need chemoradiation, and we've continued to follow her. And she got into medical school, and she sends me an email every year to give me an update, which is very heartwarming. So I think here I would argue that perhaps integrating methylation will advance the paradigm for what we do for our patients. And in fact, in our attempt to try and get this funded through our ministry or state, if you look at methylation, it will give you the IDH status, the 1p19q and MGMT. So the test may by itself be expensive, but when you cumulatively add up all the molecular tests that we currently have to do, methylation actually ends up being cheaper. And with the new WHO classification, this actually becomes a more financially feasible opportunity for us to do. So first, I wanted to talk a little bit about meningiomas and how methylation perhaps helps change practice, that treatment paradigm that I showed you. Of course, you know, meningiomas can occur anywhere in the craniospinal axis. Histopathologically, we grade them from 1 to 3. They are, in fact, the most common type of brain tumor we deal with. And in specific, if we remove the high-grade gliomas, the meningiomas end up being more than 50% of brain tumors. But we have very little research and understanding on the biology of it. If we look in the last 2 decades, there were 2 to 3 large-scale studies done in line with how we understood IDH mutation to be a defining feature of gliomas. The hope was that a mutation such as IDH comes up in meningiomas that defines aggressive versus non-aggressive. But in the mutational studies that have been done, you could see that the recurring mutations are actually very little in meningiomas. The discoveries were around NF2, which is known and recognized as a driver of meningioma formation. And then there were some recurring mutations, but really primarily this occurs in grade 1. Now, I do draw your attention that majority of the studies focused on grade 1 because that's the most common type of brain tumor of meningiomas that we get. There is a substantial number of grade 2, but very few grade 3. So it's underrepresented in these studies. Copy number alteration increases. The challenge with copy number alteration, as you know, there is no targetable agent there. And then TERT promoter mutations increase with grade, which is now incorporated into the WHO classification. So our question was clinically, is there something beyond mutation that would define good versus bad performing meningiomas? And we looked at methylation that I showed you is diagnostic and important for classification of brain tumors. We took a cohort from MD Anderson and we analyzed that by methylation. And you could see that there are distinct 2 classes of meningiomas on the heat map, one that performs favorably and one that does not do very well. So it determines outcome and it's independent of grade of the tumor. We validated this in a cohort from University of Toronto, and you could see that it's repeated again, a favorable group and an unfavorable outcome, again, independent of grade. At the time that we did this study, the DKFZ group that I showed you the methylation analysis on looked at their meningiomas as well, and they found 6 groups, but you could argue that the first one is a favorable outcome, an intermediate, and a poor outcome. There are some mutational differences between the 6 groups. They had layered mutational data onto methylation and we didn't. But these 2 data sets and publications corroborated each other and were the same message. So that was important for the literature. The question, though, is that if I have a meningioma and you tell me that I'm in the intermediate category, what is my individual outcome possibility? Do I fall on this end of the curve or do I fall at the top of the curve? So to address that, to create a personalized algorithm, we analyzed a cohort of tumors from ourselves, the group in DKFZ, and we then did methylation. There's approximately 10,000 probes that distinguish the good actor versus the bad actor. So favorable versus unfavorable are distinguished by 10,000 probes. We use that 10,000 probe to create an algorithm based on a pipeline generated that is bioinformatic with bootstrapping to then be able to give it a tumor methylation and it tells you whether it's favorable or unfavorable. And we validated this 3 times. Ultimately, for the publication, a 3rd cohort was used. And every time repeatedly, it would tell you whether it's favorable or unfavorable. And it matched the performance of the patient over the last 5 years. We then layered on this methylome-based pipeline the clinical features that we use in our clinical practice. So WHO grade, Simpson extent of resection, patient's age, location of the tumor, etc. And those that on multivariate demonstrated to be significant is WHO grade and extent of resection. So then we came up with a pipeline that distinguishes good actors versus bad, and this is independent of grade. So here you could see WHO grade 1. The predictor, the methylome, tells you that yes, majority of them perform well as expected, as we see in our practice. But in all of our practices, we have the WHO grade 1 meningioma that we fully resected, but the tumor comes back in a faster manner than you expect. And methylation tells you the subpopulation. So within WHO grade 1, what a pathologist calls a WHO grade 1, based on methylation, there is a subset that actually don't do very well. WHO grade 2 is the most controversial because we have a lot of discussions at our tumor boards, and then multiple research protocols, clinical trials have been attempted to answer this question, whether or not to give radiation to WHO grade 2. A surgeon says, I fully resected it. The MRI shows nothing on imaging. And so the question is, do we actually give radiation? Well, within grade 2, there is a subset that actually perform very well, and then the subset that do very poorly. So you could argue that this group, in fact, does not need radiation if they've had a good resection. And WHO grade 3, we automatically always assume they're bad actors. They go on to radiation. In tumor boards, that's the discussion. But really, again, in our practice, we have WHO grade 3s, and mine I do, that I've resected fully, but they don't recur, and the methylation is able to pull this population out. And we would argue that this group does not need radiation, in fact. So how does the predictor work? It's weighted to that methylome, that 10,000 probes that I said are unique to determine good versus bad outcome. It's weighted 100% to the methylome, approximately 50% to WHO grade by histopathology, and approximately 20% based on extenter resection. So in a hypothetical situation where you have a grade 2 meningioma, extenter resection is approximately a Simpson 3. The methylome based on our pipeline is 0.6. The overall score ends up being about 90%. The inverse of that is the chance of recurrence at 5 years. So the 5-year recurrence score is 60%. We then discuss this currently at our tumor board and make a decision for the patient as to whether or not to have radiation. And this is where, for example, I'll show you a resected case from outside our hospital. You could see the extenter resection is good, but there is residual. So we have a grade 2 by histopathology, Simpson 4. The predictor score is 0.098. The inverse of this is a bigger number, and this patient had a fairly aggressive recurrence at 33 months. Comparable location, comparable extenter resection, same grades. The methylome score, predictor score is much bigger than the last case, and the inverse of this is much smaller. And you could see 96 months later, without radiation, this patient has had no recurrence. So there's a number of these examples, of course. And the next question is, how do I then take this information? We publish it. We believe in the data. I just show you the data. It's compelling, I hope. How do I then convince our radiation oncologist, our pathologist to actually incorporate this? And it took us over a year to repeatedly mention this at tumor board, demonstrate its value. And we've now reached a point that, in fact, when we decide on whether or not to give radiation, our radiation oncologist requests the methylation score. So we have integrated it, and from across institutions, they send us the methylation score, we give them a predictor, and they make a decision clinically. And there's a website where you can upload your methylation and get the results. So the WHO, I'm a year behind. I keep calling it 2022, but in fact, it's 2021 that came out. I discovered it in 2022, but this is an error. It's 2021. Now does incorporate some molecular knowledge into WHO grading, not the methylation, however, because it's not a standard test that could be done in every laboratory. There are certain referral centers that do it, but more and more sites are picking up methylation. But the grading of meningiomas now relies, in addition to past histopathological features, presence of a TERT promoter mutation or homozygous deletion of the CDKN2A and 2B, but by methylation takes you into WHO grade 3. So you could see the challenge that if you don't do methylation on the tumors or any other mechanism of understanding CDKN2A loss, you may miss out on a WHO grade 3 meningioma. So with this, is there an opportunity to look at CDKN2A? So we did, in fact, we had the cohort that I showed you that we analyzed by methylation. We looked at CDKN2A by methylation. And yes, if you have CDKN2A intact or lost, the outcome is different. But then if you look at expression of CDKN2A, if it's high or low, it gives you a different outcome for the patient. And it's independent of WHO grade again. So we would argue, and we just published this in Acta Neuropathologica, that in addition to the CDKN2A being intact or being lost, the expression of CDKN2A is very important as well, because high CDKN2A means that you're an aggressive meningioma, and low expression at the RNA level means that you're a better performing meningioma. And so I think our argument is, in the publication states, that in addition to a single platform being incorporated into our decision-making, we need to use multiple platforms, which is the data I want to show you. I mentioned that they did mutation analysis in the literature and no recurring mutations were identified. So we thought that we would analyze meningiomas as one single cohort of tumors. Approximately 120 samples were collected, representing grade 1, 2, and 3 equally, because I showed you that the grade 3s were underrepresented. And we analyzed them by RNA expression, methylation, and copy number variation. And you could see that based on the molecular platform you use, you can get 6 different outcomes based on each platform. So RNA tells you there's 6 different subtypes, different outcomes. Methylation that I just showed you tells you 6 different outcomes. Copy number tells you 6 different outcomes. But most importantly, these platforms don't divide the tumors the same. As you saw in the Kaplan-Meier curves, they're very different. So if you have membership to group 6 of methylation, it doesn't mean you're the same in group 6 of RNA. And it doesn't mean you're the same 6 in copy number. And the degree of crossover you could see is significant. So then you say, well, which platform should I use? Gelleray just showed me methylation and there's value in that. But I like copy number because my colleagues down the street do copy number. So which platform do I rely on? And I think this is where we're at in the field. Which one of these platforms are more clinically relevant? And we believe the answer is to combine the platforms and generate a cluster of cluster, or integrating the different platforms that we have. So this is again a computational model where you take the 120 tumors that get divided into 6 groups based on each one of the platforms and layer them on top of each other and say, if I use all 3 information pieces, what division do I get of the 120 cohorts? And you get 4 stable divides based on COCA, cluster of clusters. And this is stable. Regardless of what you do with the algorithm, the same 4 memberships come out. There is one tumor that switches between the grade 2 to the 3. We don't understand why it does that. But otherwise, every 120, regardless of the features you set on the COCA analysis, comes up with the 4 standard stable groups. And each of them depend on copy number, RNA, and methylation to a different level. Some depend very much on methylation. Some groupings don't depend on methylation that much. So each platform defines one of the memberships uniquely. Most importantly, it has a clinical relevance. Group 1 has very good outcome. Group 4 has poor outcome, and then 2 and 3. So there is a clinical relevance to this 4 grouping. And it performs better, which is the pink line for our molecular grouping, compared to methylation and histopathology. So combining the platforms gives you an additional layer of accuracy. The question then is there a biological relevance? And if you look at the biological pathways that go into making up these 4 groups, there actually is. MG2 are a unique group that we've identified that do not have an NF mutation. So although previously we've always thought all meningiomas have NF2 mutations to drive their occurrence or growth, MG2 in fact does not have an NF2 mutation, and they have more angiogenic features. MG1 have a lot of immunogenic pathways that are upregulated, so they're immune rich. And MG4 that are the poor performers, they have the worst outcome, have most of the cell cycle and ATP pathways upregulated. They're the proliferative group. And then MG3 are the hypermetabolic. They rely on a lot of metabolic pathways. So based on RNA analysis, you can also do what's similar to an in silico drug screen, and it gives you targets. I highlight vorinostat for this purpose. Vorinostat was found to be effective for MG4, which is the proliferative, but not the other groups. And so we tested MG4 in vivo and in vitro, and I'll show you the data on that. In this set, though, I want to also point out that you can argue in a clinical trial design, when you take all comers and treat it with immune therapy, for example, obviously that clinical trial is going to fail. Because if you're proliferative and you have no upregulation of immune pathways, unlikely that you're going to respond to immune therapy. And I think this is where our field then faces a lot of failures in clinical trials. I think if you identify those that are immunogenic and give them immune therapy, you will see a response and it'll be a positive clinical trial. Whereas if you take the hypermetabolic and give them an anti-angiogenic inhibitor, there has been Avastin tried in meningiomas. All comers will not show you a positive result, and then the clinical trial will appear as though it's failed. So I think we have to be more rational in our approach to clinical trial design. The next question really is, majority of the laboratories, but all laboratories cannot do multiple platforms on a patient's individual sample day to day. So how do we convert that to a histopathological test that a pathologist can do? And this is where we added proteomic analysis. So we then did on that same 120 proteomic analysis, and you could see that by proteomics, it divides into 4 groups. And each group has a representative protein that could be stained by immunohistochemistry. So S100 falls into MG1 specifically, the group that do well. MG2 can be stained by SCGN, MG3 by ACADL, and MG4 by MCM2. I have to admit, these last 3 were not antibodies I'd be familiar with. The performance of these antibodies are good. They need to be validated in a prospective manner to make sure that if you do stain positive for S100, it is an MG1. So that step has to be completed. But this is really proof of principle discovery that shows proteomics can convert the multiple genomic platform into a test that a pathologist can do in a laboratory and tell us which of the groupings it falls into. So going to varinostat, we created cell lines from meningiomas MG1, 2, 3, and 4. MG1 2 doesn't grow very well in a dish. It's the group that didn't have the NF2 mutation. It's the group that is angiogenic. So I suspect that in vitro in a dish, they don't tend to grow. They need that angiogenic supply. But you could see that the outcome with varinostat is not uniform for all cell lines. The group that really responds to varinostat is MG4 and not MG1 and MG3. So proving my point that you can't treat all the cell lines, all the tumors with the same drug. And in vitro, vivo, you could see that in animal models where we take these same cell lines, inject them in a mouse, and it grows as a xenograft, you can decrease the growth of these cell lines and increase survival. So this is now preclinical data that allows us to take it into the next step to do a clinical trial. We published this in 2021, and a study like this requires multiple people, which is reflected in the authorship. Predominantly, I would like to thank the people that did the work for all the analysis. Farshad Nasiri is one of our senior residents who will hopefully next year come back to join us and be my colleague. And then Jeff Liu, Vikas Patel, and Yasin Mamajan are the bioinformatics that are in my lab that requires a lot of computational analysis that I have to say I understand, but if you put me in front of the computer, I couldn't do that pipeline for you. So this is the summary of what I've shown you, is that meningiomas have 4 distinct groups based on cluster of cluster analysis that's different from WHO grading. It has molecular information that drives the rationale to tell us that there are immunogenic NF2 wild type hypermetabolic proliferative. There's an immunohistochemical marker that we can identify and targeted therapeutics based on the RNA pathway that I've shown you. What I didn't show you is the single cell data, which tells us the level of heterogeneity within each of the subgroups and between, but also keeps true to the biological findings that we have for each of the 4 subgroups. I just wanted to then say that I think integrating our genomic knowledge will bear on clinical trials and really shape the way we decide how to perform or how to design clinical trials. And for me as a surgeon, it's important that we remain at the forefront of how we manage clinical trials in general. And so with that, I just wanted to, if time permits, show you the results of our most recent publication, which is the clinical trial that's a surgical trial, injection of DNA 2401, which is an adenovirus into a glioblastoma, as a phase 1/2 trial added with pembrolizumab that shows a significant benefit to patients with GBM. There's a 50% increase in survival, and the objective response rate is significantly higher. This is the cover for Nature Medicine. I joked that this is what I drew, but I didn't. I don't have such talent. So this is a histopathology piece of a glioblastoma. It's very characteristic. There's central necrosis, pseudopalisading hyperproliferative cells, very classical for a glioblastoma. A pathologist tells you this is a GBM. We've now evolved, however, from histopathology. We incorporate the molecular information that we have, which is the IDH status, defines as to whether mutant or wild type, it bears on outcome. Added to that is the knowledge of 1p19q, whether it's code-deleted or wild type, ATRX. And then now, most recently in the WHO classification, it's very much based on molecular features. So if you don't do molecular analysis in your institution, then it's difficult to actually call a tumor a glioblastoma. You would call it a high grade, not otherwise specified. And in addition to the traditional necrosis, microvascular proliferation, you need to then see the TERT promoter mutation, EGFR amplification, gain of 7, loss of 10, to be able to definitively say it's a glioblastoma. If you can't add these on, you would have to say it's high grade, not otherwise specified. But what does this ultimately mean? I did mention that other than the Stupp protocol, where it really in 2005 showed combining temozolomide and radiation together gives you a few months of additional benefit, there's been a wealth of clinical trials that have failed. And I think it's because we don't do precision type design for clinical trials. We know that the tumor microenvironment is very complex, in particular for glioblastoma, as the multiforme reflects. And we have so far traditionally targeted the tumor cells. There has been attempts to target the blood vessels with anti-angiogenic therapy. Avastin trials, however, failed. Again, I would argue that all comers of GBM were enrolled in those trials, and as a consequence, of course, the trials failed. But when I started my early career, in fact, I wrote grants on angiogenesis because that was what I did my PhD. And the reviewers in the panel said the investigator is best to focus on other areas of tumor biology. So I took my cue and I stopped writing about angiogenesis, and I looked at genomics of brain tumors, which is quite foreign to me at the time, but I learned it. So the question is, what is the immune cells doing? We know that, again, an area that's really growing very rapidly in neuro-oncology is the impact of neural stem cells, neural circuitry to advancing tumor growth. But really, what is the immune component? And why is there an interest in this? Because if you look over the last 15 years, 2 decades, there's been a wealth of immune therapy in other cancers, and many of them have actually been successful. However, when you try immune therapy by itself as a single agent in glioblastoma, again, these are failed trials, unfortunately, whether they're combined with other chemotherapies or not. So why is glioblastoma not responding to immune therapy? A recent publication from Logan Walsh, who's in Montreal, in fact, in Nature, back-to-back publications demonstrates this point, that in glioblastoma, in fact, it's a very immune silent, immune low or cold tumor. You see very few immune upregulation within the GBM compared to other tumors. And perhaps that explains why immune therapy doesn't work. So the idea of this trial came from, in fact, MD Anderson, Fred Lang, together with Juan Fuello and Candelaria Manzano Gomez, designed a virus. This adenovirus allows infection of tumor cells that are p53 deficient, replication of the virus and production of viral material, and replication of the virus and cytokines, and infection of all the tumor cells. This is the design of the adenovirus to allow for it to be safe to only target tumor cells and not normal brain. It allows it by this design to be more efficacious in its infection. And it has an effect for injecting into the, and they showed that injecting it into the mouse tumors creates a uniform distribution. Why adding pembrolizumab is important? Again, as I mentioned, there are other studies in other cancer types. This one is published by Rebus, where they show that in fact, combining temozolomide and a virus improves outcome for patients with melanoma. And so based on that rationale, the studies done in preclinical studies with this DNX2401 plus pembrolizumab shows that there's a significant improvement in outcome of patients in preclinical models. So that's the rationale as to how we went on to the phase 1/2 study. There was a separate phase 1 study of virus alone, published by Fred Lang in JCO, to demonstrate safety of the virus. So this is a phase 1, where it's a dose escalation, and we reached 5 times 10 to the power of 10 viral particles, followed by pembrolizumab, which you could see over this regimen given to the patients. The primary outcome is safety of this combination has not been tried in GBMs before. Any oncolytic virus with immunotherapy has not. So the primary outcome was safety. The secondary outcome is objective response rate, which here I'll make a note in general in neuro-oncology, an objective response rate is somewhat challenging because we always do something to the brain and there's always going to be a degree of gliosis. So complete resolution on MRI is almost impossible. So even if you use a modified RANO criteria, you're still left with a bit of a challenge as to whether there's tumor there because there's gliosis that enhances, or whether in fact there's no tumor. And so objective response rate for me is a bit challenging in neuro-oncology to use as an endpoint. What I think is important to look at overall survival. So the secondary output for this study is 12-month survival, clinical benefit, and the median overall survival. It's a multi-institutional study, and this is the study design. As I mentioned to you, the patient population is fairly standard. There's no unique features about it, and the IDH status and other molecular features are equally distributed. Most importantly, the adverse events we saw is significant edema in a few patients, but that was managed by dexamethasone, required no surgical intervention. And otherwise, as you could see, the level of grades of adverse events 1 to 5 is quite bland. Other than the edema that I mentioned, there's nothing significant here. The complete response and the partial response is, as you see in blue and green, it's notable. If the 49 patients that were enrolled in the escalation and then continued phase 2 trial, there's approximately 10 patients that had very good responses. And this gives us a very unique 12-month survival. 50% have approximately 12 months at the second recurrence. So historical data shows a 3 to 4 months increased survival. This is showing us a 12-month survival. So this is quite notable. This is an example. This is my own patient. I have to say, if somebody showed me this in a conference, I would think they're showing me cuts that don't show that recurrence. But in fact, you could see at 38 months, this patient finished the trial and the treatment. They chose to come off of pembrolizumab, and there's no evidence of tumor. And in fact, I spoke to him a couple of weeks ago before this paper came out to see whether they'd be open to speaking to the press. They're not, but in any case, their images are clear and they're doing well. They're at home. So this is that one single patient that had a very good response, a second patient that had good response and stable disease. So overall, if you combine the objective response rate, it's positive, it's statistically significant, and it's better than historical control. One of the points that we looked at, because of the significant degree of edema, prior to actually looking at this, I thought when a patient has a lot of edema, those patients have a good response and an outcome. Of course, we looked at the level of change on T2, and you could see that there is one major change in T2, the edema that I mentioned that was needing inpatient management. But otherwise, the degree of change does not correlate to the patient outcome. So although you could see a lot of edema created or a lot of reaction in the tumor picked up as edema on MRI, that did not seem to be the determining feature as to whether you have a response or not. We then looked at the IgG levels of the adenovirus in the blood. So recall that this is injected into the tumor, but you can actually pick up the adenovirus in the bloodstream, which in itself is interesting and needs a bit more investigation. But you could see that the adenovirus levels goes up in the patients, regardless of the dose, and it's a continued change in all the patients that doesn't correlate to outcome again either. We also looked at the level of it within those that were treated with the virus and pembrolizumab at different doses. Again, no difference. So then we looked at the tumor. We thought maybe we look at the genomics of the tumor to determine whether there's a biomarker there that tells you whether you respond to immunotherapy and viral combination. And you can see that in fact there is. So the protocol asked for the tumor to be biopsied for the pathologist to confirm intraoperatively that you are within tumor and it's a GBM. And then in that same location, you inject the virus over a 90-minute period with a slow pump under pressure to prevent backflow. And I would tell you that at the time we did this trial, we also enrolled in Tokagen and did the Tokagen trial. But by comparison, the Tokagen was a handheld needle that allowed us to inject the virus. And by the end of the case, everything had backflown out into the viral tumor cavity. So I think the method of delivery is very important. I do think that for us as surgeons, this is the key in changing the outcome for glioblastoma, and we can be at the leading edge of what we do. So with that, we took those samples that we had taken to prove the diagnosis from all the institutions, and we analyzed it by methylation that I showed you, and the methylation is the same for all patients. So I'm not showing you that negative result. On RNA, however, you could see that there are 3 distinct tumor types. One where it's a high expression of immune pathways, so immune upregulated, and the anti-immune pathways, the PD-1, PD-L1, CTL4, et cetera, are upregulated. There's an intermediate group, partially upregulated, and a very low, so you could say it's cold, hot, and intermediate. We then look to see how it correlates to those who had complete response or partial response. We also stained to make sure that you could see high, low, and intermediate for the immune cells. And you could see here that those that had a complete response, all of them are in the medium tissue tumor microenvironment by immune therapy, by immune signaling. So the immune signature of the medium population have a much higher response to the combination of oncolytic virus plus immune therapy. So you could see here, if you're TME low, TME medium, and high, so these groups by RNA, the outcome and response to treatment is distinct. So this immune signature will determine whether you will respond to immune therapy plus oncolytic virus or not. And this requires further validation in future studies. But we believe that there is a immunogenic signature that we've identified, that if your tumor has that signature, you will likely benefit from adenovirus plus immune therapy. And this is where we need to go, because not all comers will respond to this treatment either. We then looked at the tumors before and after, and this is a volcano plot. It looks at the genes that were upregulated before the injection, upregulation of genes after injection. We only had access to a subset of tumors for this study, but you could see that the factors that are upregulated are very distinct from those that are upregulated before injection, and majority of them, again, are related to leukocyte chemotaxis migration. There's a lot of angiogenic upregulation that may be due to the impact of what we're doing, and then neutrophil chemotaxis and all of the other interleukins that are required for immune inflammatory reaction. So clearly there's a change within the tumor that happens as a consequence of the injection of the oncolytic virus. So with this, we believe that, of course, the combination of the oncolytic virus plus immune therapy is safe, and the adverse events are manageable clinically. The most impressive is that the objective response rate is 10%, but it goes back to my earlier comments, because there's always a minor degree of enhancement on the MRI that you cannot eliminate. So really in neuro-oncology, we're challenged with that, and that objective response rate might be higher, but most definitively, it's the 12-month survival, which is 53% greater than previous studies published, so a very promising overall survival. And this is not overstating our outcomes or our results in any way. And then this really takes us to the point of where do we need to go next? And I think where we need to go next is evaluate the tumor. If it's a hot tumor, you saw that there was really very little response. If you have high immune inflammatory baseline of the tumor, and maybe you need multiple injections of or multiple doses of pembrolizumab. If you're a cold tumor and your immune signature, your immune cells are not upregulated, perhaps you need more than one injection of the adenovirus to really bring up the immune profile of the tumor so that immune therapy becomes effective. And these are where we need to go and follow up of this trial. So of course, I want to thank all the different institutions that participated and all the members that contributed to the study and the analysis. And again, a lot of the analysis I showed you are by my lab members, which are the first 4. And this was published, and I wanted to thank also all of our funding agencies for the studies that I've shown you. The International Consortium on Meningioma is an entity that we created about 2016. We have more than 40 members that allow us to share data, to share samples, and most importantly, write special editions on meningiomas to raise interest and awareness for doing meningioma research. And again, this is my 2 daughters. It's a little bit dated. I saw this slide last night. I realized they've both grown, but I have a 15-year-old and a 3-year-old who are very tolerant of my schedule. And of course, all my division members at University of Toronto, department members. Thank you very much.
Since we're sharing this with 50 other participants, I'll just repeat the questions, or Peter will. So that was unbelievable. Your passion and your organization are really outstanding. Should we open it up maybe with Dr. Germano? Do you have a question that you'd like to lead off with, or a comment?
Yeah, Larry, this is a tour de force, and you combined in a few minutes the work of over a decade. So congratulations. I think perhaps for the audience would be interesting to hear a little bit more about the ORR response and the fact that with immunotherapy, we also elicit pseudoprogression and how that could potentially limit the validity of a trial. Do you want to just spend a minute or so commenting on that?
Yeah, that's a really good question, Isabel. For this group, whether the imaging did not capture the pseudoprogression seen with immunotherapy, or as you saw on the peaks that we saw in the imaging volumetric analysis that we did, whether that was as a consequence of the pseudoprogression and not from the immune inflammatory reaction that we see. That's a good point. I have to say, we didn't tease that out.
Mm-hmm.
We have the data, we could certainly go back and tease it out, but you've given me something to think about, because the peaks that we saw were slightly delayed from when we did the injection. And I was a bit surprised because I thought we were going to see those peaks in the imaging graphs that I showed you earlier. But maybe it is that if you are seeing that pseudoprogression with immune therapy, that's why the peaks are a bit delayed, because they don't obviously start Pembro for a few weeks after that injection. So we will look at that. Actually, that might be in itself a good secondary point to publish on. Well, I'll include you. I'll talk to you.
And also you
Or
will
I'll
see
just give
today,
credit to you.
we are
Pardon?
presenting on artificial intelligence, so we might have a way to help you in speeding it up with our platform.
Yes, yeah, maybe because we have all the images
Yeah.
actually.
Yeah.
Because it's a clinical trial that was all third-party analyzed, all of this data is anonymized, so it's open for sharing, which is, I think, the value of the study.
Question. So Galerie, fantastic talk.
Thank you.
I've been following your work for many years, and it's really at the forefront for the meningioma work that I've been reading in terms of
Mhm.
the sophistication and the analysis and doing that multi-tiered approach. Your classification system is something we reviewed in our resident conference, and we actually printed out that classification scheme in our resident room, because I really do think that's the most accurate way of looking at meningiomas and behavior, and specifically how they interact. The question I have is your category that's the immune response or the immune mediated. I actually think there's a lot more that we can understand there because of the epigenetic factors that occur, particularly when you get a tumor that recurs, whether there's modulation, whether there's change in radiation. What other epigenetic factors do you think are occurring? I know there's data that says there's anatomic variability and other things as well. Do you think that changes over the course of the patient's progression?
Yeah, so super good question, and thank you very much. One of the points I would make is, how I showed the nomogram of predicting recurrence, making decision for radiation. We repeated the same nomogram for determining response to radiation. And in fact, it doesn't perform that great. It's about 60% accurate. So then we looked at the probes that determine good response to radiation versus not good response to radiation. Because the reality is, if you take all of your meningiomas that were radiated, they don't actually do that great ultimately. And we just published our clinical experience on it. There are some that do very well with radiation, but there's also an equal number that don't. So there's another approximate, don't quote me because I'm going based on my memory that's leaving me, is about another 12,000 probes that determine whether then as a meningioma, you're going to respond to radiation or not. In that group, there are pathways that are primarily related to DNA damage repair as predicted. So if you have an enrichment for those pathways, you will do better with radiation. So we will publish on the predictor that determines response to radiation. The epigenetic alterations in those that respond well to radiation and don't really cross over to the immunogenic nature of the tumor. But that specific question, again, you've given me a good thought, which is why it's good to go to different places, think of different ideas. We haven't actually gone into the depth of all the methylation-driven pathways of the 4 subtypes, because there's other projects that we're focusing on. But that's a very good question, in that I think that's what you're asking me. I show you the RNA pathway and how it defines it biologically. But if you look at those 4 pathways or 4 subtypes and look at methylation-driven pathways, are there CpG islands that are unmethylated or methylated that tell you they're pushing the tumor in that direction? Now, the rationale would be that because these groupings are defined by a combination of methylation, RNA, and copy number, there has to be an integration of these signals to come up with that ultimate pathway. But yeah, that's a very good question. I have to write it down somewhere, and Isabel's idea. This has been a very fruitful visit. Thank you.
Clinically speaking, would it make sense to do a biopsy prior to surgery on these meningiomas to identify which ones would respond better to some type of treatment, and that would potentially alter your type of surgery, whether you're more aggressive or not?
Yeah, that's a very good question. I mean, I think typically we operate on meningiomas because there's a mass effect and a local impact to the brain. So I'm not sure that we would ever come up, unlike medulloblastomas, where one of the subtypes surgery doesn't really bear on the outcome. I'm not sure for meningiomas we'd get there, but what I think would be good, which is in line to what you're saying, is if we did a phase 0 pre-surgical trial, and you give a drug of choice, immunotherapy or vorinostat, to the meningioma, you resect the tumor, and then you profile it, A, for pharmacokinetics to see if it made it into the tumor, has good distribution, and 2, to see whether the signature of the tumor matches the treatment that you've given them, and then follow them. It's a complex study because it requires long follow-up. But where the biopsy might come into play is if you do the biopsy and you see it's immunogenic, then you give immune therapy, and then you take out the tumor because you have to take it out anyways. And then you see whether you change the signal of the tumor. The question is, would our IRB or REB in Canada agree to this sort of protocol? Because that first biopsy is, you could argue, not necessary. But that would be the ideal. You do a biopsy, it puts it into one of the 4 MG classes, you give the drug and you see if it changes it. In particular, for a drug like vorinostat, does it change the methylation signature, to your point, to the level where then it impacts the RNA expression? Because that's the challenge with epigenetic modifiers.
But it would also impact your degree of surgery. How radical are you going to be into removing the dura if it's in a location that's not that easy to remove it? So
yeah, I suppose you could argue for some types of tumors, not all of them. I mean, I think there's standard cases that we do. We have to resect the tumor. But there are, the ones that are challenging where we don't remove it, but this is my opinion about gliomas as well. There's a reason why we couldn't remove it completely. It wasn't just because I gave up and I left the OR early. It's because it's bounded by some eloquence. So I think when you go after the tumor, you take it all out when you can, And then the cases you can't is because you were trying to preserve neurological structures or vascular structures. Yeah, I'd have to think about it. I'm not sure. I think the only place where that biopsy would help currently in my mind is to see whether you're switching the subtypes by treatment.
Follow-up, I guess they can hear us. A follow-up on that. I noticed that the 4 different groups differentiated themselves on the Kaplan-Meier curves very quickly, particularly the 1 from the 4, MG1 from the 4. So taking Frank's question and kind of turning it around a little bit, would there be a difference between waiting for those to differentiate themselves, going after the ones that recur visibly within that 6 to 12 months, and then just going after those? Would there be a difference in the outcome?
Yes, so that's a really good question. I didn't show you data I did with the Bittner lecture. You can actually detect the subtypes in the plasma based on the circulating tumor DNA. That's data I didn't show for interest of time. So we published about 2 years ago in Nature Medicine, the plasma that's captured, the circulating tumor DNA that's captured in the plasma can then be analyzed by methylation. That methylation signature could then tell you which of the 4 groups you belong to. It's not very high accuracy, but it's with accuracy enough that you could argue if you see a patient with a moderate sized meningioma, but they're asymptomatic, and the CF-MEDIP, the circulating tumor DNA methylation, shows that they're MG1, you don't have to really rush into operating on them. But if they're MG4, then you need to prioritize and prevent them from getting to the bottom part. Yes, yeah. The performance of the CF-MEDIP, though, has to be supplemented with another feature. So whether it's imaging, we're exploring that now, or as mentioned earlier, the biopsy to confirm that. That I think would be a reasonable reason to actually proceed with the biopsy.
Great. Is Dolores, Dolores, are you here? Do you have a
I do
comment or
see a question. Yeah. Oh, I see. No. Do you understand this question?
Thank you so much for a great talk.
Mhm.
I just had one question. Are you seeing any intra-sample variation temporally with your methylome status? So, I mean, some of these obviously can be followed for an appreciably long time, and we know that the methylome can change over time in other disease states or in normal states like aging. Have you seen any intra-sample variations that of one type of tumor switching on their methylome status to another over time without?
Yeah, that's a very good question as well. We don't have the cohort size to answer your question. We have approximately 20 cases where a meningioma recurs, and we have both samples. We have a little bit more that we've accumulated since this publication, but the issue really is in that cohort, we don't see a change, but I think you need larger numbers to answer your question. The other piece is that within a tumor, if you sample different areas, you don't see a difference in the methylation. Now, on gliomas, I'll tell you we have a cohort of 100 primary recurrent pairs that we've analyzed. The methylation doesn't change in a wild-type glioblastoma on recurrence. It also doesn't change if you go from IDH mutant to an IDH mutant of the same grade. But if you go from an IDH mutant to a higher grade, then the methylation changes. So reflecting something probably more aggressive that happens. But on meningiomas, I think in order to see the group where it goes from a 1 to a 3, you need multiple institutions to pool those samples. And within the group that we only have 8 that went from 1 to 3. Clearly, we have more in our practice, but we only have access to the multiple plots.
Dolores, did you have any comments? You're on mute, Dolores.
Yeah, okay, good. I wasn't able to, I was listening, but I wasn't able to ask questions and stuff in my chart. Well, that was a very, very beautiful talk. And I realized this is the first time I hear you giving a talk, surprisingly. So I think I wanted to ask a question about your totem pseudo progression that you have with immunotherapies and oncolytic viruses, right? And that is that you think in a long term, because you saw also pseudo progression with bevacizumab when tumor change the phenotype becomes more invasive. So I wonder that pseudo progression, which is probably mainly inflammatory reaction locally when you kill the tumor cells with oncolytic virus, we recruit more inflammatory cells there to clean the debris, but they can later on be converted into more pro-tumorogenic phenotype. Do you think this can in a long run affect the invasion of tumor or the phenotype of the tumor?
Yeah, I think similar to what Isabel asked me, if I'm understanding your question, it's possible, though in the cohort of the study protocol of the clinical trial, we didn't see that phenomenon that you're mentioning. Now, how would I prove that they're more invasive? It would just be on imaging, correct? That's what you're asking me?
Yes,
Whether
later
the
on,
combination-
not
Yes.
immediately,
Well,
but down the road.
Yeah. I mean, it's going to be a tough question to answer in general because the longevity of GBMs unfortunately is so low. Of those who had a complete response or partial response, on imaging, we don't see the phenomenon you described, similar to what you see with Avastin, where there is that subset that have the extreme invasive nature that happens after treatment, which I think is what you're asking me.
Yes.
Yeah, we haven't seen it in this cohort and this study. But I suppose it's possible, though you would have thought we'd see a few of them do that.
Oh, it's interesting. Because I don't know if you are familiar, I think it's a Canadian group. It was also a very multi-institutional effort. Then they look at the tumors with constitutional mismatch repair deficiency syndrome patients, and they had that germline, they have these mutations. And they
Oh,
had,
yes, that's right.
Yes, they had an immunotherapy trial in these patients, and 3 GBM patients responded, but all 3 of them had a pseudo progression. And then they were sent home, and the effects of immunotherapy came like very, very late, that they showed the survival advantage in the end. But initially they showed pseudo progression.
Yeah, and I do think Isabel's question is good because maybe the peak that we're seeing in the T2 change is from the pseudo progression.
Yeah.
The invasive nature, though, you would imagine that in the trial you're mentioning, if they did survive to become that invasive, but the survival was an advantage, then of course it's positive in a way.
Yeah, thank you.
I might not be understanding your question fully though.
No, you did. That's good.
Yes,
Thank you so much for the interesting talk.
Thank you.
I noticed in your meningioma cohort in your trial, you focused mainly on cranial meningiomas. I'm not sure if your lab has looked at this, but in the cases of spinal meningiomas, do you think it's fair to extrapolate the same genomic data in terms of methylation status, copy number variation, or do you think this warrants kind of its own scope into the specific genetic drivers?
yeah, again, a super good question. I get asked that quite a bit. The spinal cohort is waiting for somebody to analyze it because it's just beyond our bandwidth of doing that. The interesting point I find for the spinal meningiomas, it's rare to get a grade 2 or a grade 3. And so it would be nice to see whether their genomic signature is, as you said, exactly that we see in cranial or different. I imagine it'll be different because the biology and the behavior, clinical behavior is very different. I mean, I don't do a lot of spine surgery anymore, but spine tumors we do as oncology surgeons at our place. It's almost never that I've seen a meningioma intradurally recur after a complete resection, but in cranial you do. So there's got to be something that's unique about their biology.
The question is a little beyond the scope of the science, but we've seen this explosion in every brain tumor type and using methylation, RNA, DNA mutation, proteomics in classifying them better, understanding the behavior, guiding therapy. How do we apply this across health systems?
Yeah,
I mean,
exactly.
it's very different in Canada than it is in the United States, but you could imagine a scenario where it would force everyone with any type of tumor to come to a large center. That might not be feasible.
I do think the proteomics is the step that will convert these high intensity genomic analysis to a laboratory test. So what I showed you in the 4 subtypes where S100B is with 86% accuracy, picking up MG1. The next step of the study has to be done where a blinded pathology reviews them, and then we do the analysis to see that it fits those 4 groups. Once that's completed, then you could say with accuracy, you could use that test. And S100 is pretty standard. It's inexpensive compared to all the genomic tests. So that is how I think then you make it a more broadly applicable test. And I think you're correct. If you look at all the mutational data, the other genomic platforms where people subdivide tumors, for example, medulloblastomas, it isn't one small test that gives you the results. But I think it's that necessary step to convert it to something that any institution's histology lab can do.
Great, thank you very much.
Thank you.
So we'll move to Zoom. So in about 10 minutes, we'll get started with the research day presentations on Zoom, the same link that everyone should have. So we'll adjourn.
Okay, great, thank you.
Thank you. Peter, should I close?
We're good to catch up with you at some point. I don't know what days of the week are good for you.
Thank you, gallery.
Can you see it or should I'll text it?
No, Tuesday, I not my own work days. I catch you,
Okay.
Tuesday morning. I'm just on Sunday. You're Sunday. Okay, good. All right.
Definitely.
Yes.
I do. I mean, at the moment, I'm working with